afternoon, class. Today we're going to start Unit 11, Chapter 17, Blood.
There is one tissue that clinicians examine more than any other when trying to determine the causes of disease in their patients. This tissue is the blood. Blood is the only fluid tissue in the body and accounts for approximately 8% of your body weight. It serves as a transport vehicle for the circulatory system, acting out many critical functions in the body, which include delivering oxygen from the lungs and nutrients from the digestive tract to body cells. When a blood vessel is damaged and causes your patient to bleed, cells within the blood form clots. This process halts further blood loss from the body and is called the hemostasis response. As a healthcare professional, it's critical that you understand the process of the hemostasis response so that you can help your patients prevent abnormal blood clots in their body. For example, a patient who remains in a hospital bed for an extended period of time may develop blood clots in their legs. These clots are known as deep vein thrombosis, or DVTs. The danger of this type of blood clot is that a piece of it could break off and travel to the lungs, causing a pulmonary embolism or even death. You can help your patients prevent these conditions by encouraging them to be active, whether that means walking, if possible, or exercising in their bed as their condition permits. Exercise helps the patient's veins push blood back up to the heart, keeping it from sitting where clots are likely to form. A solid understanding of the anatomy and physiology of the blood will enable you to help your patients prevent dangerous blood clots like DVTs.
Internal transport system. So blood is the fluid component of the cardiovascular system, which also includes a pump, the heart, that circulates the fluid, and a series of conducting pipes, the blood vessels, that carry it throughout the body. So we've already looked at the heart, the anatomy of the heart, the physiology of the heart, and we've also looked at blood vessels. And so now we're going to concentrate on blood. Functions of blood, section 17.1, include transport, regulation, and protection. Transport functions include delivering oxygen and nutrients to the body cells, transporting metabolic waste to the lungs and kidneys for elimination, and transporting hormones from the endocrine organs to target organs. Regulation functions include maintaining body temperature by absorbing and distributing heat, maintaining a normal pH using buffers, the alkaline reserve of bicarbonate ions, and maintaining adequate fluid volume in the circulatory system. Protection functions include preventing blood loss, so plasma proteins and platelets in blood initiate clot formation, preventing infection. Agents of immunity are carried in blood like antibodies, complement proteins, and white blood cells. Section 17.2, composition of blood. So blood is the only fluid tissue in the body. It's a type of connective tissue, as you remember, and the matrix is a non-living fluid called plasma, and cells are living blood cells called formed elements, and the cells are suspended in the liquid plasma. The three formed elements of blood are the erythrocytes, or red blood cells, leukocytes, or white blood cells, and the platelets. A spun tube of blood yields three layers: the erythrocytes on the bottom, which make up 45% of the whole blood. An hematocrit is a percent of blood volume that is red blood cells. Normal values are 47% plus or minus 5 for males, and for females 42% plus or minus 5%. We are going to do an hematocrit this week in the lab. And white blood cells and platelets in the buffy layer, that is about 1%. And this is a thin whitish layer between red blood cells and plasma layers. And plasma on top is 55%. So figure 17.1, the major components of whole blood. So if you would draw blood and place it in a tube, and then you centrifuge the blood sample, then you will get these layerings. So at the bottom is the erythrocytes, which is about 45% of the hematocrit. It's the most dense component. And in the middle, there's a buffy coat, which is less than 1% of whole blood. This would be the leukocytes and platelets. And then on top, it would be the plasma, which is 55%, which is the least dense component. Physical characteristics and volume. So blood is a sticky, opaque fluid with a metallic taste. The color varies with oxygen content. High oxygen levels show a scarlet red. Low oxygen levels show a dark red. The pH of blood, very important, is between 7.35 to 7.45. And it makes up, and blood makes up about 8% of body weight. And the average volume in males is between 5 to 6 liters, and in females 4 to 5 liters. Let's start looking at blood plasma and then formed elements after. So blood plasma is straw-colored sticky fluid, and it's about 90% water. There are over 100 dissolved solutes in plasma. There's nutrients, gases, hormones, wastes, proteins, and inorganic ions. Plasma proteins are the most abundant solute. They remain in blood and are not taken up by cells. And these proteins, the blood proteins, are produced mostly by the liver. Albumin is a protein that makes up 60% of plasma proteins. It functions as a carrier of other molecules. It also functions as a blood buffer and contributes to the plasma osmotic pressure. Table 17.1, composition of plasma. So it's mostly water, 90% of the plasma volume. The function of water could also be not just for dissolving medium for solutes, but also it absorbs heat. Then there's electrolytes and things like sodium, potassium, calcium, magnesium, chloride, phosphate, sulfate, and bicarbonate. And these are very important because they maintain the osmotic pressure and also normal blood pH. And then there's the plasma proteins, 8% by weight. So these play a variety of functions. So albumin is the most predominant protein. It's produced by the liver and the main contributor to osmotic pressure. Then there's globulins, which make up 36% of plasma proteins. There's alpha and beta. These are also produced by the liver. And most are transport proteins that bind to lipids, metal ions, and fat-soluble vitamins. The gamma globulins, these are antibodies released by plasma cells during an immune response. Fibrinogen, this is 4% of plasma proteins, and it's produced by the liver, and its job is involved in blood clotting. Also, other components or constituents of plasma are non-protein nitrogenous substances. These are byproducts of cellular metabolism, such as urea, uric acid, creatinine, and ammonium salts, for example, from the breakdown of proteins and amino acids. Nutrients, organic nutrients, these are they're absorbed from the digestive tract and then they're transported to use throughout the body. These would be things like glucose and other simple carbohydrates, amino acids, fatty acids, cholesterol, and vitamins. And of course, then there's the respiratory gases, right, like oxygen and carbon dioxide. We learned in the last chapter that oxygen is mostly bound to hemoglobin inside red blood cells, whereas carbon dioxide is transported, dissolved as bicarbonate ion or CO2 or bound to hemoglobin in red blood cells. And then there's also hormones like steroid hormones, for example, estrogen, progesterone, testosterone, and thyroid hormones that are carried by plasma proteins. The formed elements are red blood cells, white blood cells, and platelets. Only white blood cells are complete cells with a nucleus. So, for example, red blood cells have no nuclei or other organelles, and platelets are simply cell fragments. Most formed elements survive in bloodstream only for a few days. Most blood cells originate in the bone marrow and do not divide. Figure 17.2a, blood cells. So we can see the three components, formed elements. So the leukocytes, the erythrocytes, and the platelets. Here is a blood smear, figure 17.2b. We've already seen it. You can see the red blood cells, the erythrocytes, the white blood cells. There's different types of white blood cells. There's monocytes, lymphocytes, neutrophils, and eosinophils. We are going to learn about these. And then you see those little cell fragments called platelets. Section 17.3, erythrocytes. Structural characteristics. So erythrocytes have a small diameter, about 7.5 micrometers, that contribute to gas transport. The cells are described as biconcave discs, and they are anucleate, which means that they don't have a nucleus and pretty much don't have any organelles, but they are filled with hemoglobin for gas transport because that's what their function is. Red blood cells' diameters are larger than some capillaries. However, because they are biconcave discs, they can change their shape. And they contain plasma membrane protein spectrin and other proteins, and spectrin provides the flexibility to change shape. So spectrin, as well as their biconcave disc shape, allows them to squeeze through the narrow walls of the capillaries. So this is it's a really good example of complementarity of structure and function, where the structure determines the function of these cells. Three features make for efficient gas transport. The biconcave shape offers a huge surface area relative to volume for gas exchange. Hemoglobin makes up 97% of the cell volume, not counting water. And red blood cells have no mitochondria. ATP production is anaerobic, so they do not consume oxygen, the oxygen they transport. They are very selfless, these red blood cells. So figure 17.3 is a structure of a red blood cell, a side view showing how thick it is. It's 2.5 micrometers, and the length from a top view is 7.5 micrometers. Notice how they are hollow in the center, which is a very good adaptation for them, like so, where they can be more efficient at squeezing through the narrow walls of capillaries. So red blood cells are dedicated to respiratory gas transport. Hemoglobin binds reversely with oxygen. Normal values in males are 13 to 18 grams per 100 mils. For females, 12 to 16 grams per 100 mil. Hemoglobin consists of a red heme pigment bound to the protein globin. Globin is composed of 4 polypeptide chains. There are 2 alpha and 2 beta chains. A heme pigment is bonded to each globin chain, and that's what gives the blood that red color. And each heme's central iron atom binds 1 oxygen. Figure 17.4a, the structure of hemoglobin. Notice that it has these 4 polypeptide chains, and these are called globins, 2 alpha chains and 2 beta chains. And at the center of each chain is the heme group that will bind to oxygen. Figure 17.4b, iron-containing heme pigment. So at the center of the heme is iron, and iron is what binds to oxygen. So function of erythrocytes as continued. So each hemoglobin molecule can transport 4 oxygens, and each red blood cell contains 250 million hemoglobin molecules. Oxygen loading in the lungs produces oxyhemoglobin. That's when the blood is ruby red because it's really rich in oxygen. And then at the level of tissues, oxygen unloading in the tissues, it produces deoxyhemoglobin or reduced hemoglobin, and the blood is dark red. CO2 loading in the tissues So 20% of carbon dioxide in blood binds to hemoglobin, producing carbaminohemoglobin. Our erythrocytes produced, the process is called hematopoiesis. It's actually formation of all blood cells. It occurs in the red bone marrow, and it's composed of reticular connective tissue and blood sinusoids. In the adult, they're found in the exoskeleton, in the girdles, like the pelvic girdle, and the proximal epiphysis of the humerus and femur bones. Hematopoietic stem cells, also known as hemocytoblasts. So the stem cell that gives rise to all formed elements. Hormones and growth factors push the cell toward a specific pathway of blood cell development, and committed cells cannot change. So the new blood cells enter the blood sinusoids. Stages of erythropoiesis. So erythropoiesis is the process of formation of red blood cells that takes about 15 days. So stages of transformations are: 1, hematopoietic stem cell transforms into myeloid stem cell. The myeloid stem cell transforms into a proerythroblast. The proerythroblast divides many times, transforming into basophilic erythroblasts, and basophilic erythroblasts synthesize many ribosomes which stain blue. Stage 5, polychromatic erythroblasts synthesize large amounts of red-hued hemoglobin. The cell now shows both pink and blue areas. Orthochromatic erythroblasts contain mostly hemoglobin, so appear just pink. And this is when they eject most organelles. The nucleus degrades, causing the concave shape. And then reticulocytes still contain small amounts of ribosomes. And then a mature erythrocyte is within 2 days. The ribosomes degrade, transforming into a mature red blood cell. Reticulocyte count indicates the rate of red blood cell formation. Figure 17.5, erythropoiesis, formation of red blood cells. So we have a stem cell, which is called hematopoietic stem cell. Once it's a committed cell, it's a proerythroblast. And then there's, in the developmental pathway, phase 1 is ribosome synthesis. Here we have a basophilic erythroblast. In phase 2, this is when hemoglobin accumulates. It's first a polychromatic erythroblast, then an orthochromatic erythroblast. Notice in phase 3 there's ejection of the nucleus, and then just before an erythrocyte we have a reticulocyte, and then we have the familiar erythrocyte with the biconcave shape. Regulation and requirements of erythropoiesis. So too few red blood cells lead to tissue hypoxia, because not enough oxygen is delivered to the tissues. Too many red blood cells increases blood viscosity. So more than 2 million red blood cells are made per second. So there's a balance between red blood cell production and destruction, which depends on hormonal controls and dietary requirements. So let's look at hormonal control. So EPO, or erythropoietin, is a hormone that stimulates the formation of red blood cells. There's always a small amount of EPO in the blood to maintain this basal rate, and it's released by the kidneys, some usually from the kidneys, but some from the liver, in response to hypoxia. So at low oxygen levels, oxygen-sensitive enzymes in the kidney cells cannot degrade hypoxia-inducible factor, and so this factor, HIF, can accumulate, which triggers the synthesis of EPO. Some causes of hypoxia are decreased red blood cell numbers due to hemorrhage or increased destruction. Another one would be insufficient hemoglobin per red blood cell, as in iron deficiency, and reduced availability of oxygen, for example, in high altitudes, or if a person has lung problems such as pneumonia. Too many erythrocytes or high oxygen levels in the blood will inhibit EPO production. EPO causes erythrocytes to mature faster. So testosterone will enhance EPO production, resulting in a higher red blood cell count in male. Figure 17.6, erythropoietin mechanism for regulating erythropoiesis. So homeostasis is basically keeping normal blood oxygen levels. So the stimulus for erythropoiesis is hypoxia or inadequate oxygen delivery due to a decreased red blood cell count, decreased amount of hemoglobin, or decreased availability of oxygen. So this stimulus will target the kidney and liver to a smaller extent to release EPO. EPO stimulates the red bone marrow, and then there's, as a result, enhanced erythropoiesis, which increases red blood cell count, and then oxygen carrying ability of blood will rise. And so then normal blood oxygen levels will be restored. Clinical homeostatic imbalance 17.1. So in the past, some athletes have abused of artificial EPO. So they would use EPO, which increases the hematocrit, which allows the athlete to increase their stamina and performance. Now, this had dangerous consequences because EPO can increase the hematocrit from 45% up to 65%. With dehydration concentrating blood even more. And the blood becomes like sludge and can cause clotting, stroke, or heart failure. So they were noticing that some very young healthy athletes were having a stroke, and then when they investigated, they saw that they were abusing of artificial EPO. Dietary requirements for erythropoiesis. So very important to make blood. Amino acids, lipids, and carbohydrates are essential. Iron is available from the diet. So 65% of iron is bound in hemoglobin, with the rest in the liver, spleen, and bone marrow. Free ions are toxic, so iron is bound with proteins. So it's stored in the cells as ferritin and hemosiderin, and transported in the blood bound to the protein transferrin. Also important and essential is vitamin B12 and folic acid, and these are necessary for DNA synthesis for rapidly dividing cells, such as developing red blood cells. Fate and destruction of erythrocytes. So red blood cells have a lifespan of 100 to 120 days. Red blood cells, as we know, are anucleates, so they cannot synthesize new proteins or grow or divide. All red blood cells become fragile, and hemoglobin begins to degenerate. So they can get trapped in smaller circulatory channels, especially in the spleen. Macrophages in the spleen engulf and break down dying red blood cells. When red blood cells break down, heme, iron, and globin are separated. The iron binds to ferritin or hemosiderin and is stored for reuse. Heme is degraded to the yellow pigment bilirubin, and the liver secretes bilirubin in bile into the intestines, where it is degraded to the pigment urobilinogen. Urobilinogen is transformed into brown pigment stercobilin that leaves the body in feces. Globin is metabolized into amino acids, because of course globin is a polypeptide, and it's released into circulation. Life cycle of red blood cells, figure 17.7. So low oxygen levels in blood stimulates the kidneys to produce EPO. Levels rise in the blood. EPO and necessary raw materials in blood promote erythropoiesis in red bone marrow. So new erythrocytes enter the bloodstream, and they function at about 120 days. Aged and damaged red blood cells are engulfed by macrophages of the spleen, liver, and bone marrow, then the hemoglobin is broken down. So the hemoglobin is broken down into globin, which is broken down into amino acids, which go into blood. It's broken down to heme, and the iron is stored as ferritin or hemosiderin. And the heme is also broken down into bilirubin, which is picked up by the liver. So the iron that is bound to transferrin is released to the blood from the liver as needed for erythropoiesis, whereas the bilirubin is secreted into the intestine in bile, where it is metabolized to sarcobilin by bacteria, and then it is excreted in feces. So raw materials are made available in blood for erythrocytes synthesized from the food nutrients, things like amino acids, iron, B12, vitamin B12, and folic acid. So they're absorbed from the intestine and they will enter the blood so that there's all the raw materials needed to make red blood cells. Erythrocyte disorders. So most erythrocyte disorders are classified as either anemia or polycythemia. In anemia, blood has an abnormally low oxygen carrying capacity that is too low to support normal metabolism. Sign of problem rather than a disease itself. Symptoms are fatigue, pallor, dyspnea, and chills. There are three groups based on the cause: blood loss, not enough red blood cells produced, or too many red blood cells being destroyed. Look at anemia due to blood loss. So two examples are hemorrhagic anemia, like a rapid blood loss due to a severe wound, and this of course is treated by blood replacement, or chronic hemorrhagic anemia. This is slight but persistent blood loss due to hemorrhoids or bleeding ulcers. The primary problem must be treated to stop the blood loss. The second cause for anemia, not enough red blood cells being produced. So this is called iron deficiency anemia. It can be caused by hemorrhagic anemia, but also by low iron intake or impaired absorption. Red blood cells produced are called microcytes. They're small, pale in color. They cannot synthesize hemoglobin because there's a lack of iron, and the treatment is supplementing with iron. Pernicious anemia is an autoimmune disease that destroys the stomach mucosa that produces intrinsic factor, and intrinsic factor is needed to absorb vitamin B12, and B12, as we know, is needed to help red blood cells divide. Without B12, red blood cells enlarge, but they cannot divide, and it results in large cells called macrocytes, and the treatment is B12 injections or a nasal gel. It can also be caused by low dietary intake of B12, which can be a problem for vegetarians, strict vegetarians. Under the cause of not enough red blood cells being produced, there is renal anemia, which is caused by a lack of EPO. It often accompanies renal disease, and where kidneys cannot produce enough EPO, and the treatment is synthetic EPO. Aplastic anemia is due to a destruction or inhibition of red bone marrow. It can be caused by drugs, chemicals, radiation, or viruses. Usually the cause is unknown. All formed element cell lines are affected. It results in anemia as well as clotting and immunity defects. Treatment short-term using transfusions, and long-term with transplanted stem cells. The third cause of anemia is too many red blood cells destroyed. So premature lysis of red blood cells, this is referred to as hemolytic anemias. It can be caused by incompatible transfusions or infections, or hemoglobin abnormalities, and this is usually genetic, resulting in abnormal globin. So two examples are thalassemias and sickle cell anemia. Thalassemias are typically seen in people of Mediterranean descent. One globin chain is absent or faulty, and the result is red blood cells that are thin, delicate, and deficient in hemoglobin. Many subtypes that range in severity from mild to extremely severe, and in very severe cases, people would require monthly blood transfusions. Sickle cell anemia, hemoglobin S is a mutated hemoglobin molecule. Only one amino acid is wrong in the globin beta chain of 146 amino acids. So it's basically there's been a substitution of one amino acid for the other, so there's been a mutation. Red blood cells become crescent-shaped when oxygen levels are low, for example, during exercise. And this misshaped red blood cells, they rupture easily and block small vessels, and the result is poor oxygen delivery and pain. Sickle cell anemia is prevalent in Black people of the African malarial belt and their descendants. However, it will confer upon them a possible benefit. People with sickle cell do not contract malaria. It kills 1 million people each year, and malaria is still a problem in certain parts of the world. And individuals with 2 copies of the hemoglobin S can develop sickle cell anemia, and individuals with only 1 copy have a milder disease, and on top of that, they have this benefit of having a better chance of surviving malaria. Treatment: acute crisis treated with transfusions or inhaled nitric oxide. The prevention of sickling, hydroxyurea induces formation of fetal hemoglobin, which does not sickle. Stem cell transplants, gene therapy, where they insert the correct gene so that in the bone marrow so that it produces the correct hemoglobin, and nitric oxide for vasodilation to prevent blood clots in small arteries. Figure 17.8, sickle cell anemia. So here it shows just a section of the polypeptide chain. Here with the amino acids, there are 146 amino acids per globin chain, and a normal erythrocytes has the normal hemoglobin amino acid sequence. So in other words, at position number 6, the amino acid is glutamic acid, and that will result in a normal red blood cell shape. Whereas in figure B, there's been a mutation, and the result is at position number 6, there's a valine instead of a glutamic acid. These are 2 completely different amino acids, and because there are so many hemoglobin molecules per red blood cell, the result is this sickle shape of the red blood cell. Polycythemia is when there's an abnormal excess of red blood cells, which increases blood viscosity, causing sluggish blood flow. Polycythemia vera, this is due to bone marrow cancer leading to excess red blood cells. The hematocrit may go as high as 80%, and treatment is therapeutic phlebotomy. In a secondary polycythemia, this is caused by low oxygen levels, for example, in a situation of high altitude, or increased EPO production. Blood doping is when athletes remove, store, and reinfuse red blood cells, their own red blood cells, before an event to increase oxygen levels for stamina. 17.4, leukocytes. General structure and functional characteristics. Leukocytes or white blood cells are only are the only formed element that is a complete cell with nuclei and organelles, but they make up less than 1% of the total blood volume. There's about 4,800 to 10,800 white blood cells per microliter of blood. And they function in defense against disease. They can leave the capillaries via diapedesis and move through the tissue spaces by amoeboid motion and positive chemotaxis. Positive chemotaxis means that they are moving in the direction of whatever pathogen that they are sensing. Leukocytosis is when the white blood cell count is over 11,000 per microliters. An increase is a normal response to infection. Leukocytes are grouped into two major categories, granulocytes and agranulocytes. Granulocytes contain visible cytoplasmic granules, and examples of these are neutrophils, eosinophils, and basophils, whereas agranulocytes do not contain those visible cytoplasmic granules, and the two examples are lymphocytes and monocytes. A mnemonic to remember decreasing abundance in blood is never let monkeys eat bananas. So never neutrophils, let lymphocytes, monkeys, monocytes, eosinophils eat, and basophils are bananas. Figure 17.1, types and relative percentages of leukocytes in normal blood. The blood consists mostly of erythrocytes, then there's leukocytes and platelets. So of the leukocytes, we have neutrophils that are about 50 to 70% of the white blood cells. We're looking at a differential white blood cell count. All total is between 4,800 and 10,800 microliters, as we said. Eosinophils, these are 2 to 4%. Basophils are 0.5 to 1%. In the agranulocytes, the lymphocytes constitute 25 to 45%, and monocytes 3 to 8%. Figure 17.10, leukocytes. So if you look at the difference between granulocytes and agranulocytes, you notice this difference in the texture. Granulocytes appear granular in appearance, whereas agranulocytes not really. So neutrophils, their characteristic is that they have a multi-lobed nucleus. They are pale red and blue. So they have pale red and blue cytoplasmic granules. The eosinophils, these are a bilobed, they have a bilobed nucleus and red cytoplasmic granules. Basophils, these have a bilobed nucleus, purplish black cytoplasmic granules. Lymphocytes are small, large, they have a large spherical nucleus. Notice it's mostly nucleus and a thin rim of pale blue cytoplasm. Lymphocytes are really easy to recognize because of this large nucleus. And monocytes have a kidney-shaped nucleus and abundant pale blue cytoplasm. There are three types of granulocytes: neutrophils, eosinophils, and basophils. Granulocytes are larger and shorter lived than red blood cells. They contain a lobed rather than circular nucleus. The cytoplasmic granules stain specifically with Wright's stain. It's a specific stain. And all are phagocytic to some degree. So they're all capable of phagocytosis, if you remember one type of endocytosis. Neutrophils are the most numerous white blood cells. They account for 50 to 70% of white blood cells. They're about twice the size of a red blood cell. Granules stain with both acid and basic dyes. Granules contain either hydrolytic enzymes or antimicrobial proteins called defensins. That are particularly useful against bacteria. These are also called polymorphonuclear leukocytes, PMNs or polys, because the nucleus is lobular, and the cell has anywhere from 3 to 6 lobes. Neutrophils are very phagocytic. They are referred to as bacteria slayers. They kill microbes by a process called respiratory burst. The cell synthesizes a potent oxidizing substance, bleach or hydrogen peroxide, and then the defensin granules merge with the phagosome and form spears that pierce holes in the membrane of ingested microbes. Here again is a picture of neutrophils. Notice the multi-lobed nucleus, they're very large cells, and the pale red and blue cytoplasmic granules. Eosinophils account for 2 to 4% of all leukocytes. The nucleus has 2 lobes connected by a broad band, resembles earmuffs. They have a red staining granules that contain digestive enzymes, and they release enzymes on large parasitic worms digesting their surface. Also play a role in allergies and asthma, as well as immune response modulators. So if someone has a parasitic infection, then their numbers would increase. The eosinophil numbers would increase. And this is what they look like. So the bilobed nucleus and red cytoplasmic granules. Basophils are the rarest white blood cells, accounting for only 0.5 to 1% of leukocytes. The nucleus is deep purple with 1 to 2 constrictions. Large purplish black basophilic granules contain histamine, and histamine is an inflammatory chemical that acts as a vasodilator and attracts white blood cells to the inflamed sites, and they are functionally similar to mast cells. This figure shows a basophil with the bilobed nucleus, although that's not really obvious, purplish black cytoplasmic granules. Agranulocytes lack a visible cytoplasmic granules. There are 2 types, lymphocytes and monocytes, and both have spherical or kidney-shaped nuclei. Lymphocytes are the second most numerous white blood cell that account for 25% of white blood cell count. They're large, dark purple, and they have circular nuclei with thin rim of blue cytoplasm. Mostly found in lymphoid tissue, example lymph nodes in the spleen, but a few circulate in blood. They are crucial to immunity. There are 2 types of lymphocytes. T lymphocytes, also known as T cells, these are specifically they act specifically against virus-infected cells and also tumor cells, and B lymphocytes or B cells that give rise to plasma cells which produce antibodies. So here in figure 1710D, we see lymphocytes, these small cells with a large spherical nucleus. Remember we said before that it occupies most of the cell, and a thin rim of pale blue cytoplasm. Monocytes are the largest of all leukocytes, and they account for 3 to 8% of all white blood cells. They have abundant pale blue cytoplasm, dark purple staining, U or kidney-shaped nucleus. They leave circulation, enter the cells, and then they will differentiate into macrophages. Macrophages means big eaters, which are actively phagocytic cells, crucial against viruses, intracellular bacterial parasites, and chronic infections. And they activate lymphocytes to mount an immune response. So here is an image, figure E, of a monocyte with the kidney-shaped nucleus and an abundant pale blue cytoplasm. And lifespan of leukocytes. Leukopoiesis, or production of white blood cells, are stimulated by 2 types of chemical messengers from red bone marrow in mature white blood cells. Interleukins that are numbered IL-3, IL-5, and colony-stimulating factors, or CSFs, and these are named for white blood cell type they stimulate, like granulocyte CSF stimulates granulocytes. All leukocytes originate from hematocytoblast stem cell that branches into 2 pathways. Lymphoid stem cells produce lymphocytes, and myeloid stem cells produce all other elements. Granulocyte production. So first step, myeloblasts arise from myeloid line stem cells. Promyelocytes accumulate lysosomes. Myelocytes accumulate granules. Band cells are nuclei. The nuclei form curved arc. Mature granulocyte, the nuclei become segmented before being released in blood. There are 10 times more that are stored in bone marrow than in blood. And 3 times more red blood cells are formed than red blood cells, because white blood cells have a shorter life and it's cut short by fighting microbes. Monocyte production. So let's look at monocytes. These are derived from the myeloid line. So a monoblast becomes a promonocyte, and then a promonocyte becomes a monocyte. So they share common precursor with neutrophils, and they can live for several months. Lymphocytes instead are derived from the lymphoid line. The T lymphocyte precursors give rise to immature T lymphocytes that mature in the thymus, so T for thymus. The B lymphocyte precursors give rise to immature B lymphocytes that mature within the bone marrow. And lymphocytes live from a few hours to decades. Figure 1711, leukocyte formation. So we have the stem cell, the hematopoietic stem cell, hematocytoblast, that gives rise to 2 stem cell lines. If we look at the myeloid, it can give rise to myeloblasts, and these can develop into promyelocytes, eosinophilic myelocytes, eosinophilic band cells, and then eosinophils. The myeloblast, if you look at the second row, promyelocyte, basophilic myelocyte, basophilic band cells that give rise to basophils. Myeloblast, the third row, can give rise to neutrophils. And the fourth row, the monoblast, can give rise to the promonocyte, which gives rise to monocytes, but can in tissues, some can become macrophages. If you look at the lymphoid stem cell, there are 2 precursors, B lymphocytes and T lymphocytes. The B lymphocytes some become plasma cells, and the T lymphocytes, some become effector T cells. Homeostatic imbalance 17.2. This is actually not, I guess it is an homeostatic imbalance, but many hematopoietic hormones like EPO and the CSFs are used clinically because they can stimulate bone marrow of a cancer patient receiving chemotherapy or in stem cell transplants. Also can be used to increase the protective immune response in people with AIDS. Leukocyte disorders. Overproduction of abnormal white blood cell are called leukemias and infectious mononucleosis, and an abnormally low white blood cell count is called leukopenia. It can be drug-induced, particularly by anti-cancer drugs or glucocorticoids. Leukemias is a cancerous condition involving an overproduction of abnormal white blood cells. Usually involves clones of single abnormal cell, and named according to the abnormal white blood cell clone that is involved. So myeloid leukemia involves myeloblast descendants, whereas lymphocytic leukemia involves lymphocytes. Acute or quickly advancing leukemia derives from stem cells and primarily affects children, whereas a chronic or slowly advancing leukemia involves the proliferation of later cell stages and is more prevalent in older people. Without treatment, all leukemias are fatal. Immature non-functional white blood cells flood the bloodstream, and cancerous cells fill the red bone marrow, crowding out other cell lines, which leads to anemia and bleeding. Death is usually from internal hemorrhage or overwhelming infections. Treatments include irradiation, interleukemic drugs, and stem cell transplants. Infectious mononucleosis is another leukocyte disorder, highly contagious viral disease. It's called the kissing disease. It's usually seen in young adults, and it's caused by the Epstein-Barr virus. It results in high numbers of typical agranulocytes. It involves lymphocytes that become enlarged. Originally thought cells were monocytes, so the disease is named mononucleosis. Symptoms are tired, achy, chronic sore throat, and low fever, and it runs its course with rest between 4 to 6 weeks. Section 17.5, platelets. So a platelet is a fragment of larger megakaryocyte, blue staining outer region, purple granules. It contains several chemicals involved in blood clotting like serotonin, calcium, enzymes, ADP, platelet-derived growth factor. Function, it forms a temporary platelet plug that helps seal breaks in blood vessels. Circulating platelets are kept inactive and mobile by nitric oxide and prostacyclin from endothelial cells lining the blood vessels. Platelet formation is regulated by Erythropoietin. It's formed in myeloid, myeloid line from megakaryoblast, stage 1 megakaryocyte. Mitosis occurs but no cytokinesis, resulting in large stage 4 cell with multilobed nucleus. The stage 4 megakaryocyte sends cytoplasmic projections into the lumen of the capillary, and projections break off into platelet fragments. Platelets age quickly and degenerate in about 10 days. So normally, there are 150,000 to 400,000 platelets per ml of blood. Figure 1712 shows the formation of platelets from a stem cell, the hematocytoblast, and then it turns into megakaryoblast, which is stage 1. Stage 2 and 3 is a megakaryocyte, and then a megakaryocyte, stage 4, starts to fragment into platelets. Table 17.2, summary of formed elements of the blood. So this table summarizes everything we've done. So it's very good for review. So erythrocytes shows you what it looks like. It gives you the description. It shows you what the how much is found in blood, and duration. So lifespan, duration and lifespan, duration of development and lifespan, and then its function. Leukocytes, the granulocytes and the agranulocytes, and then the platelets. Section 17.6, hemostasis. So hemostasis is a fast series of reactions for basically to stop bleeding. It requires clotting factors and substances released by platelets and the injured tissues. There are 3 steps that are involved. Step 1 is vascular spasm. Step 2 is the platelet plug formation. And step 3 is coagulation or blood clotting. 1, vascular spasm. So vessel responds to injury with vasoconstriction. So vascular spasms are triggered by direct injury to the vascular smooth muscle, chemicals released by the endothelial cells and platelets, and pain reflexes. It's the most effective in smaller blood vessels and can significantly reduce blood flow until other mechanisms can kick in. Step 2 is platelet plug formation. So in this step, platelets stick to collagen fibers that are exposed when the vessel is damaged. Platelets do not stick to the intact vessel walls because collagen is not exposed. Prostacyclins and nitric oxide secreted by endothelial cells act to prevent platelet sticking. Von Willebrand factor helps to stabilize platelet collagen adhesion. When activated, platelets swell, become spiked and sticky, and release chemical messengers. ADP causes more platelets to stick and release their contents. Serotonin and thromboxane A2 enhance vascular spasm and platelet aggregation. There's a positive feedback cycle, which we've already discussed. As more platelets stick, they release more chemicals, which cause more platelets to stick and release more chemicals. And the platelet plugs are fine for small vessel tears, but larger breaks in vessels need the additional step. Step 3 is coagulation or blood clotting that reinforces the platelet plug with fibrin threads. Blood clots are effective in sealing larger vessel breaks. Blood is transformed from a liquid to a gel, and there's a series of reactions using clotting factors or procoagulants, mostly plasma proteins, that are numbered 1 to 13 in the order of discovery, and vitamin K is needed to synthesize 4 of those factors. Coagulation occurs in 3 phases. Figure 1713, events of hemostasis. So in step 1, vascular spasm, smooth muscle contracts causing vasoconstriction. In step 2, platelet plug formation, so injury to the endothelium lining the vessel exposes the underlying collagen fibers, and platelets will adhere to it. Platelets release chemicals that make nearby platelets sticky, and there's a platelet plug that forms. And thirdly, coagulation. Fibrin proteins form a mesh that traps red blood cells and platelets, forming the clot. Phase 1 coagulation involves 2 pathways to prothrombin activator. So it's initiated by either intrinsic or extrinsic pathway, usually both. So it's triggered by the tissue damaging effects, involves a series of procoagulants, and each pathway cascades toward and ends with the activation of factor X. Factor X then complexes with calcium, PF3, which is platelet factor 3, and factor 5 to form prothrombin activator. The intrinsic pathway, called intrinsic because clotting factors are present within the blood, is triggered by negatively charged surfaces such as activated platelets, collagen, or even glass of a test tube. Extrinsic pathway, called extrinsic because factors are needed for clotting, are located outside the blood, and it's triggered by exposure to tissue factor, also called factor 3. And this pathway bypasses several steps of the intrinsic pathway, so it's a faster one. Figure 1714, the intrinsic and extrinsic pathways of blood clotting. So phase 1, these are in phase 1. So intrinsic pathway, vessel endothelium ruptures, exposing the underlying tissues like collagen. Platelets cling and their surfaces provide sites for mobilization of factors from 12. So you see this cascade effect and these complexes that finally will link to prothrombin activator. And you can see the extrinsic pathway is much faster because it produces this tissue factor, and this complex is going to activate X, and then eventually we have a prothrombin activator, which consists of factors X, A, VA, calcium, and phospholipid surface. Of course, you don't need to know these pathways. Phase 2 is the pathway to thrombin. So prothrombin activator catalyzes transformation of prothrombin to activate the enzyme thrombin. So in phase 2, prothrombin 2 is activated to thrombin 2A. Phase 3 is common pathway to the fibrin mesh. Thrombin converts soluble fibrinogen to fibrin. Fibrin strands form the structural basis of a clot. Fibrin causes the plasma to become a gel-like trap, catching formed elements. And thrombin, along with calcium, activates factor 8, which is the fibrin stabilizing factor, which cross-links fibrin and strengthens and stabilizes a clot. You've heard of anticoagulants. These are factors that normally dominate in blood to inhibit coagulation. So phase 3, fibrinogen is converted to fibrin, which is an insoluble polymer, and then with 13A and calcium, it forms a cross-linked fibrin mesh. And this figure shows the 3 phases, the complete pathway and cascade effect from the three phases. So the end result after injury is a cross-link fibrin mesh. Figure 1715 shows a scanning electron micrograph of red blood cells that are trapped in this fibrin mesh. Table 17.3 shows the 13 factors and their name, their nature, their source, and their pathway and function. Clot retraction and fibrinolysis. So the clot must be stabilized and removed when damage has been repaired. A clot retraction, actin and myosin in platelets contract within 30 to 60 minutes. Contraction pulls on the fibrin strands, squeezing the serum from the clot. Serum is plasma minus the clotting proteins, and it draws ruptured blood vessel edges together. The vessel is healing even as clot retraction occurs. Platelet-derived growth factor is released by the platelets. It stimulates the division of smooth muscle cells and fibroblasts to rebuild the blood vessel wall. Vascular endothelium growth factor stimulates the endothelial cells to multiply and restore the endothelial lining. Fibrinolysis is a process whereby clots are removed after repair is completed. It begins within 2 days and continues for several days until the clot is dissolved. Plasminogen is a plasma protein that is trapped in clot and is converted into plasmin, a fibrin-digesting enzyme. Tissue plasminogen activator, factor 12, and thrombin all play a role in the conversion process. Factors limiting normal clot growth. So 2 mechanisms limit clot size: swift removal and dilution of clotting factors, inhibition of activated clotting factors. Limited amount of thrombin is restricted to clot by fibrin threads, preventing the clot from getting too big or escaping into the bloodstream. Antithrombin 3 inactivates any unbound thrombin that escapes into the bloodstream. Heparin in basophil and mast cells inhibit thrombin by enhancing antithrombin 3. Factors preventing undesirable clotting. So factors preventing platelet adhesion are the smooth endothelium of blood vessels prevents platelets from clinging. Endothelial cells secrete antithrombic substances such as nitric oxide and prostacyclin. Vitamin E quinone, formed when vitamin E reacts with oxygen, is a potent anticoagulant, which maybe, as you know, before surgery, it's good to maybe not be on vitamin E supplements because then it prevents healing. Disorders of hemostasis. So there are 2 major types of disorders: thromboembolic disorders that result in undesirable clot formation, and bleeding disorders, which are abnormalities that prevent normal clot formation. Disseminated intravascular coagulation involves both types of disorders. Thromboembolic conditions, thrombi and emboli. A thrombus is a clot that develops and persists in unbroken blood vessel. It may block circulation, leading to tissue death. An embolus is a thrombus freely floating in bloodstream. An embolism is an embolus obstructing a vessel, for example, in pulmonary or cerebral emboli. Risk factors are atherosclerosis, inflammation, slowly flowing blood, or blood stasis from immobility, like being in an airplane for a long time and not moving around. Anticoagulant drugs, these are used to prevent undesirable clotting. Most notorious one is aspirin. It's an antiprostaglandin that inhibits thromboxane A2 and lowers heart attack incidence by 50%. Heparin is used clinically for pre- and post-operative cardiac care as well as to prevent venous thrombosis. Warfarin and direct oral anticoagulants reduce the risk of a stroke in patients that are prone to atrial fibrillation, in which the blood pools in the heart. And this interferes with the action of vitamin K. Disorders. Thrombocytopenia is a deficient number of circulating platelets. Petechia appear as a result of spontaneous widespread hemorrhage. So this is something that appears on the skin, these little red spots. And it's due to suppression or destruction of red bone marrow, examples in malignancy, radiation, or some drugs. And the platelet count is less than 50,000 per microliter, and this is a diagnostic. Treatment is transfusion of concentrated platelets. 1716 shows petechias. In impaired liver function, there's the inability to synthesize procoagulants or clotting factors, and the causes include vitamin K deficiency, hepatitis, or cirrhosis. Liver disease can also prevent the liver from producing bile, which is needed to absorb fat and vitamin K. Hemophilia includes several similar hereditary bleeding disorders. Hemophilia A is the most common type. About 77, it accounts for 77% of all cases, and it's due to a factor VIII deficiency. Hemophilia B is due to a factor IX deficiency, whereas hemophilia C is due to factor XI deficiency, and it's milder. Symptoms include prolonged bleeding, especially into the joint cavities, and treatment is injections of genetically engineered factors, which has eliminated the need for a plasma transfusion and the risk of contracting hepatitis or HIV. Disseminated intravascular coagulation, or DIC, involves both widespread clotting and severe bleeding. Widespread clotting occurs in intact blood vessels, blocking blood flow. Severe bleeding follows because residual blood is unable to clot because clotting factors are being depleted. It can occur in septicemia, which is a blood, it's due to, let's say, bacteria in the blood, for example, incompatible blood transfusions, or complications in pregnancy. Section 17.7, blood transfusions. The cardiovascular system minimizes the effects of blood loss by 1, reducing volume of affected blood vessels, and 2, by stepping up production of red blood cells. The body can compensate for only so much blood loss. A loss of 15 to 30% causes pallor and weakness. Loss of more than 30% results in potentially fatal severe shock. Restoring blood volume. So death from shock may result from low blood volume. Volume must be replaced immediately with a normal saline or multiple electrolyte solution called Bringer solution that has all of the electrolytes in the right concentration, so usually 0.9% salinity, that mimics plasma electrolyte composition. The replacement of volume restores adequate circulation, but does not replace the oxygen carrying capacities of red blood cells. Transfusing red blood cells. Whole blood transfusions are used only when blood loss is rapid and substantial. Fusions of packed red blood cells, or PRBCs, plasma and white blood cells removed, are preferred to restore oxygen carrying capacity. The blood banks usually separate donated blood into components, and the shelf life of blood is about 35 days. Human blood groups of donated blood must be determined because transfusion reactions can be fatal. So blood typing will determine the blood group. Human blood groups. So red blood cell membranes have many antigens. So an antigen is anything perceived as foreign that can generate an immune response. So red blood cell antigens are referred to as agglutinogens because they promote agglutination. So these are basically, located on the surface of the red blood cells. Mismatched transfused blood is perceived as foreign and may be agglutinated and destroyed, and this can lead to a potentially fatal reaction. Humans have at least 30 naturally occurring red blood cell antigens. The presence or absence of each antigen is used to classify blood cells into different groups. So there are some blood groups like the MNS, Duffy, Kell, and Lewis. These are only weak agglutinogens, and they're not usually typed unless the patient will need several transfusions. Antigens of the ABO and RH blood groups cause the most vigorous transfusion reactions. Therefore, they are the major groups that are typed. So the ABO blood groups are based on the presence or absence of two agglutinogens, A and B, on the surface of red blood cells. So type A people have only A agglutinogens. Type B has only B agglutinogens. Type AB has both A and B antigens, whereas type O has neither A nor B agglutinogens. So the blood may contain preformed anti-A or anti-B antibodies. They're called agglutinins. These act against the transfused red blood cells with the ABO antigens that are not present on the recipient's red blood cells. Anti-A or anti-B form in the blood at about 2 months of age, reaching adult levels by 8 to 10 years of age. 17.4 shows the ABO blood groups. So if your blood group is AB, that means you have both A and B antigens on the surface of the red blood cells. And it also means that you do not have any antibodies to either one of these. So there's a picture of a red blood cell, and it shows both A and B antigens. So people of this blood group can receive blood from A people, B people, AB, and O people, so they are called the universal recipients. And this is the frequency in a US population. In Canada, it's very similar. People who are B have B antigens on the surface of the red blood cells. That means they also have A and anti-A antibodies. And the blood that can receive is blood from B people and O people, and that is the frequency. And these frequencies will differ depending on the population. So North American population is very typical of this. A people, these means that you have A antigens on the surface of the red blood cells. That means you have B antibodies, anti-B antibodies, anti-B antibodies, yes. And that means you can receive blood from A people and O people. And these are the most common in general in a population. And O people are O, meaning that they don't have either one of those antigens on the surface of the blood cells, but they have both antibodies, A and B. And the O is the universal donor. So this blood type is the universal donor, and they're predominant in our population. The other blood group is called the RH blood groups. 52 named RH agglutinogens or R factors, and C, D, and E are the most common. RH positive means that there is the D antigen is present. 85% of North Americans are Rh positive. Anti-Rh antibodies are not spontaneously formed in Rh negative individuals. So an anti-Rh antibodies form if the Rh negative individual receives Rh positive blood, or if an Rh negative mom is carrying an Rh positive fetus. The problem arises with a second exposure to the Rh positive blood, which will result in a typical transfusion reaction. Homeostatic imbalance 17.3, hemolytic disease of a newborn, also called erythroblastosis fetalis, only occurs if we have an Rh negative mom that is carrying an Rh positive fetus. So in the first pregnancy, the Rh negative mom is exposed to the Rh positive blood of the fetus during delivery, but the first baby is born healthy. But the mother now, upon exposure, will synthesize the anti-Rh antibodies. The second pregnancy is where the problem is, or any subsequent pregnancy after that. the mom's anti-Rh antibodies cross the placenta and destroy the red blood cells of the Rh positive baby, and the baby is treated with a pre-birth transfusions and exchange transfusions after birth. RhoGAM is a serum that contains anti-Rh, and this can be given to the mom, the Rh negative mom, to or mothers, right? And this can prevent the mother from being sensitized. So this here is given if the pregnant mother is Rh negative and her partner is Rh positive, so potentially they would be having an Rh positive fetus. Transfusion reactions occur if mismatched blood is infused. The donor cells are attacked by the recipient's plasma agglutinins that agglutinate and clog the small vessels, and these rupture and release hemoglobin into the bloodstream. And the result results in a diminished oxygen carrying capacity, a decreased blood flow beyond blocked vessel, and hemoglobin in the kidney tubules could lead to renal failure. Symptoms are fever, chills, low blood pressure, rapid heartbeat, nausea, and vomiting. And treatment is preventing kidney damage with fluids and diuretics to wash out the hemoglobin. So we said type O is the universal donor. It does not have any A or B antigens, whereas type AB is the universal recipient. It doesn't have any anti-A or anti-B antibodies. It's misleading, as other agglutinogens that cause transfusion reactions must also be considered. So this is only really a problem with people who always require transfusion reactions. Autologous transfusions, the patient pre-donates their own blood that is stored and available if needed to avoid transfusion reactions. So in blood typing, the donor blood is mixed with antibodies against the common agglutinogens. If the agglutinogen is present, there is clumping of the red blood cells, which is visible. And then the blood is typed for ABO and for Rh factor in the same manner. Cross-matching is a type of typing between the recipient donor and specific recipient. So you mix recipient's serum with the donor red blood cells, and you mix the recipient's red blood cells with the donor serum. Figure 1717, blood typing of ABO blood types. So here the blood being tested is AB, and it contains both antigen A and antigen B, and agglutinates with both sera, as we can see here. So we see clumping or agglutination. Type A contains antigen A, and it agglutinates with anti-A, as we can see here. Type B contains antigen B, so it agglutinates with antibody B. Whereas type O, which contains no antigens, but it does not agglutinate with either serum. Section 17.8, diagnostic blood tests. Examination of blood can yield information on a person's health. Low hematocrit seen in cases of anemia. Blood glucose tests will check for diabetes, and leukocytosis can signal infection. Microscopic examination of blood can reveal any variations in size or shape of red blood cells. So we're looking for things like an abnormal shape, size, shape, or color that could indicate one of the different types of anemia. Section 17.8, diagnostic blood tests. So differential white blood cell count looks at the relative proportion of each white blood cell, and it increases in a specific white blood cell can help with diagnosis. So for example, an increase in eosinophils can indicate a parasite infection, or it could also indicate an allergic reaction. Prothrombin time and platelet counts assess hemostasis. CMP, or Comprehensive Medical Panel, is a blood chemistry profile that checks various blood chemical levels. Abnormal results could indicate liver or kidney disorders, and a complete blood count, or CBC, checks the formed elements, the hematocrit, and hemoglobin.